Right, hello everyone. Thank you very much for coming. This week is HIV Awareness and Testing Week, which is why we've put this on in this week. And then specifically, we have got people like John from Body Positive and other guys from Over the Rainbow to talk to you as well about things more specific to your guys' placements and going out into placement and how you should treat people with HIV and stuff. So really specific to health and social care students. I know some of you have got to go at 2. You're really putting me off. We're gonna try and not run over time. But if you do have to go, feel free to just go. So I'm going to hand over to John from Body Positive. Thank you.
Fantastic. Thank you, Sophie. Just picking up on what Sophie was saying about going quite fast, this is the kind of pace that I'm going to go at, and I know that Kevin is able to go even faster. So if you get really lost because of time, just stop me and I'll repeat, but we are going to go quite fast, okay? Just to reiterate, I am Jonathan Owen, I'm the Education Officer, and I'm also HIV positive, so I'm a client of Body Positive Dorset, okay? So please feel free to ask me anything that you want to during, and if we run out of time afterwards, down in the Boho Lounge. Okay, I'll be there for a bit. Okay, so I'm going to do the kind of slightly whingy bit at the beginning about stigma within the NHS, and then there's a really fun bit with all the clinical information that comes from Over the Rainbow. Okay, so apologies if this is a bit whingy. I just want to say stigma in the NHS, little caveat to that, we're not talking about the whole NHS. Okay, these are some case studies that we've come across within our own charity. Anybody that works in sexual health, the GUM, knows about this stuff, and none of this stigma applies to them. Okay, but we want to make sure that you guys go out into the workplace, into your placements, armed with some knowledge. Okay, some awareness about some of the discrimination issues that do still sadly come up. Okay, so moving on, a little bit about Body Positive Dorset itself. What is it? This is our building. What do you notice about the building itself? Throw some words at me. It's like a house. Yeah, exactly. So we are not a clinical service. Okay, we're a charity, and we actually offer support for all people infected or affected by HIV in Dorset. A lot of people come to us the same day they're diagnosed. Staff at GUM actually will refer through to us. And so people can come to us in a state of shock, quite traumatised, possibly being prodded, poked, needles in the arm, all that sort of stuff. Last thing I want to see is more people in white coats. So we get the kettle on, we do all that stuff, okay? We then do an assessment, and we work out a suitable care programme for somebody. So that could involve some of the services, which actually I'll come on to on the next slide. That's just really cheesy to say that we are here to support everybody. HIV doesn't discriminate, okay? We're all susceptible to HIV infection, so we don't discriminate either. We are not just an LGBT service. So, who do we support? That has now ticked over to 600 service users or clients we prefer. No prizes for being the 600th, sadly. We're both men and women come and see us. The split, probably majority men still, but it is still split. Some are gay, some are straight, probably about half and half now. Last count, 13 different ethnicities, okay. So again, doesn't discriminate, and anybody can access our service. It's a completely free service. You don't have to be a resident in the country for any length of time to access our service. Friends and family can also come and see us, because HIV can affect them as well. Just to highlight that actually you can lead a happy, successful life with near normal life expectancy. Our founder's just turned 74, okay, he's still a service user. In fact, our youngest was born with HIV and is now 12, so quite a span there. So the sorts of services we offer, just very, very briefly, emotional support, peer support, we offer cognitive behavioural therapy, more traditional forms of therapy as well. We have gender-specific support groups, and there's a lot of sort of soft support that happens around the biscuit tin as well. Practical support, our support workers can offer back-to-work guidance, can do an assessment of financial needs, housing support, benefits advice. We also have a grant programme where people can access if they can't pay a utility bill, and also access tools to get back to work, laptops, etc. Training and outreach, that's my bit, and I love it. And this is the sort of thing that we do in schools, universities, colleges, really broad spectrum of education. Complementary therapies, my favourite person in the building is Mary, who's our masseuse, I can never say that, female masseur. And she offers all sorts of stress-busting therapies. Mental health and HIV still go together hand in hand. We see a lot of anxiety, depression, stress. We also see sometimes, not so much anymore, but we still see some people with internalised discrimination and stigma issues where human contact is an issue shortly after diagnosis. So safe, non-sexualised human contact can be quite reassuring for somebody, okay? And then lots of parties and fun stuff, and we do lots of work on self-esteem, disclosure, helping people come out to their families, etc., as being HIV positive, getting people back into the community, showing that they can still have a job, can go to pubs. We see a lot of agoraphobia and people that actually kind of isolate quite a bit, so we do a lot of work with that. Okay, so moving on to the stigma bit. This is a quote, "Be the change you wish to see in the world," which I really, really love, and it's on the wall in your own school, Health and Social Care. I saw it and it really inspired me. I want you to hang on to that and keep that in your mind as we go through the next bits about stigma. Think about that. Okay, this figure here, 80%, this relates to the number of HIV discrimination cases that we see as a charity that involve a health professional. Okay, so 80% of those discrimination cases relate to a health professional. It's quite shocking. We obviously want to reduce that closer to zero with your help. Okay, we're doing a lot of joined up work now with the GUM and the hospital around training and education, so I'm sure we will get there with your support. Why is HIV important? Just a few bits, just to focus on mine. Health protection agencies, sort of latest stance on it. They're still saying it's one of the most important diseases in the UK. Serious morbidity, high costs, significant mortality, and potential years of life lost, the four main issues there. And we're going to look a little bit about how many new diagnoses in a second. Okay, and again, the stigma is still there. Okay, we actually see some service users who receive death threats or threats of physical harm just for accessing our service. It tends to be within the BME community for all cultural, religious purposes. But yeah, there is still a lot of stigma there. Okay. Right, very quick snapshot. I'm not going to dwell on this because I know that Over the Rainbow chaps are going to go through all of this. So just a bit of a crib for you. When you get to there, you'll know the answers. Fabulous. Okay, because I'm glossing over that, just be aware of these. Fix those in your mind. You're probably aware of a lot of them. This is where you can access more information. These are kind of your nationals. Okay, Health Protection Agency, I'm sure you know about. These are three of the biggest sort of HIV and AIDS charities and resources for information. All of them have fantastic web pages where you can download lots of resources and things. And then your globals, UNAIDS, and also the WHO as well, where you can access lots of statistics. Health Protection Agency do a report every year where you can get lots and lots of information as well. HIV in the UK, I think it's called, isn't it? It is HIV in the UK, this will call it. So you can get your up-to-date statistics year on year. Right, I'm going to go very quickly through this again because actually Kevin's going to go through this and he's got some more accurate figures. Again, a bit of a crib for you, so just if you've got the subliminal. Right, quick game with bodily fluids before we move on to stigma. Shout some of those at me, the ones that you think actually can pass on HIV. Which are risk? Blood, yeah. Breast milk, yeah. Semen, yeah. Yeah. One more. Fabulous. Okay, brilliant. So again, bit of a crib there for you. All the others, not a risk at all. HIV dies outside the body very, very quickly, within about 7 seconds. Again, Billy and Cordelia are going to go into the clinical side in more detail in a sec, so I'm not going to dwell. Right, this is kind of my main bit, discrimination. THG did a survey, it's a little bit old now, but it is the most up-to-date survey that we've got, which showed about a third of people with HIV experience some form of discrimination. Quite shocking. More worryingly, half said it came from a healthcare worker, 1 in 4 from a dentist, 1 in 5 from a GP, and 1 in 10 from hospital staff. Okay, so quite shocking. I've now got some case studies for you. I'm going to go as fast as I can. So these are all real anonymised case studies that we've gathered from our service users. So the first one looks at refusal of treatment. So Mike had, Cordelia again.
Otosclerosis.
Very good, thank you. Can't say it. Causing hearing loss. In March 2011, he saw his ENT consultant at Hull, who explained his options, and he actually elected for surgery. Okay, this is the letter that actually came out, or part of the list that came back from his consultant, okay. Quite shocking. Okay, so talking about double gloving, okay, and in fact not even sure if they can perform the surgery. So this was the outcome of that. Mike actually was referred to 3 different hospitals in total, and he's still waiting for that to happen. He's still not had his surgery, okay, and his hearing is obviously still deteriorating. So I've interviewed all the chaps involved. This is what Mike actually said, okay, so this is his own words about how he feels about it, and that rejection word came up twice, okay. So we're talking about a group of people who are already stigmatised, already marginalised, feeling more stigma from the people who are supposed to care for them. Okay, so it really has a double sort of whammy if it comes to a healthcare professional. Right, let's be absolutely clear. Refusal of treatment based on somebody's HIV status, unless it's in their own interest, is illegal. Okay, there's absolutely no grey area on that. Okay, and this is part of the Equalities Act, which actually sort of links to that. So let's just be absolutely clear on that one. All right. So let's just go back to the letter that the ENT surgeon sent through. I think the big issue, or the motivation, is probably quite noble. He was afraid for his staff. Okay, his own ignorance about HIV meant that he wanted to protect his own staff. But I would say that it was an irrational fear. Okay, because one should never refuse treatment because someone is HIV positive. This is what's come back from our service users. This is what they would like to see. Okay, double gloving. There's absolutely no evidence that that has any effect whatsoever at minimising infection. So let's just bin double gloving once and for all. If you're ever asked to do it, it's totally unnecessary. You don't need any special precautions because somebody's HIV positive in terms of hygiene. Okay. Number 2, unnecessary hygiene. Kind of picking up what we were just saying. So in February 2012, Fiona was admitted to a Dorset hospital, again not Bournemouth. She stayed overnight as an inpatient and actually used the phone on the ward. After she hung up, this is what one of the staff actually said, okay? So I'm really glad to hear that swing, because that obviously means that you're all far more enlightened and would never ever do that, okay? But it does happen still in 2013, all right? Obviously this was the outcome. So Fiona herself may have overheard it. The student nurse was showing a very bad example. It was a student nurse that actually flagged this up to us, so good on her, and highlighted quite a staggering level of ignorance. So this is what the nurse, student nurse actually said about it, okay? So obviously her kind of role model, gone, didn't trust that person, and what she said was she actually wasn't sure how to confront it. So you may well find yourselves when you get on your placements or into new places of work thinking, God, you know, we're dealing with somebody whose HIV knowledge perhaps hasn't been updated in the last 20 years, okay, and you've actually got a more up-to-date view on things. How do you go about dealing with stigma and discrimination if you come across it? Make sure you know what the anonymous route is. You don't have to speak to your clinical lead. There should be some mechanism for reporting back discrimination anonymously. Okay, so find out about that one. Okay. So let's be absolutely clear. It's unnecessary. Okay, standard precautions. Who's looked at standard precautions already? Is that something you've done?
Yeah.
You will be doing. Okay. You'll be doing a lot more about that, I'm sure. I'm not going to do it to death. But there's absolutely nothing in the standard precautions that says that anybody with HIV needs any special precautions. Okay. So we need to basically be assuming that all patients could have all infections. All right, that's the stance. And our service users said about this one, please, 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 never treat HIV positive people like they're dirty. All right, how am I doing, Sophie? Where are we? You okay?
Yeah, you got 7 minutes.
Fabulous. Okay, even faster. Okay, confidentiality breach. Christine was staying as an inpatient in a Dorset hospital, again, not Bournemouth. She must take antiretroviral therapy for HIV. She was told she couldn't keep those medications in her bedside locker, which is absolutely fine. If that is hospital procedure for safety, health and safety, that's fine. However, this is what happened. Okay, so intercams, okay, so I have your HIV medication now, across the board. Not great, okay. So Christine was obviously very worried about her HIV status being declared across the board, and any repercussions from that. And this is what Christine actually said about it. She was actually really angry about it, and it goes back to that respect and dignity thing. Okay, so just being a bit sensitive to how people might be feeling. All right. So again, it's unprofessional. This is what the GMC actually say about it. So just be aware. I want everybody to be aware that it could potentially be a disciplinary matter if they go away. We don't want to see anybody in any hot water. Just be thinking about your standard confidentiality. That involves conversations, bits of paper you leave around, conversations with friends and family. Very often friends and family don't know about somebody's HIV status until they actually pass away. We have had cases where people have only found out about a family member's HIV status because it's on the death certificate. But, okay, so just be aware of that, okay? Don't know why that's missing. Okay, so this is the little request that came back from our service users. Please protect the confidentiality of all HIV positive people. Okay, number 4, inappropriate questions. So Peter needed a triple heart bypass. He was told by the consultant that it would not, his HIV would not affect his treatment, and he went into Bournemouth January last year. Really bizarre. Middle of the night, nurse came in to do a rounds, usual procedures. In the course of the conversation she had with him, this question came in. And I can say that is singularly the most annoying question that HIV positive people get asked. We get more complaints about this question than any other, okay? Reason being is that it pisses people off. There was some press actually picked up, and this is what's driven this particular initiative about HIV stigma in the NHS. But the main reason is that there's an inference of indirect homophobia. So there's a sort of suggestion that the way you got HIV will have some effect on your treatment. It must never have any effect on your treatment. Okay, it's totally irrelevant. You never ever need to ask anybody what, how, or why they got their HIV unless you're in a GRM setting, perhaps. Okay. So, and obviously Data Protection Act kind of enforces that, and we should not be asking irrelevant or excessive questions. Okay. So this is what came back off the back of that one from service users. Again, it's going back to the respecting the privacy. Okay, right, very quickly, I think, last on the list. Alex required arthroscopic surgery, so the surgery in the knee. Pre-op team again assured Alex that his HIV would have absolutely no effect on his treatment. And in March last year, he went into Bournemouth. Okay, this is what he was told as he was being sort of prepped for surgery. Okay, really bizarre statement. You are special precautions, quite dehumanising, I think. And this is what the outcome was. Alex was obviously really fed up. Surgery had to be rescheduled, an apology issued. The real significant issue is that if surgery keeps overrunning and the HIV positive person is always last on the list, you can have repeated cancellations. So we know people 4 or 5 times they've had the surgery put off. Okay, never any need to put anybody last on the list who's HIV positive. This is what Alex actually said about it. So he felt like being told to get to the back of the bus, which made me think about Rosa Parks. Anybody know who this person is? Human rights campaigner who said that she refused to sit at the back of the bus in 1950s Alabama. Okay. So it's totally illogical. This idea that things need to be properly sterilised, can we just bin that entirely? Things are either sterile or they're not. And you would hope that between every procedure in theatre, everything would be sterile. Okay. So HIV positive people can be done first, middle, end, doesn't matter. Okay. And this is what came back from our service users. Please don't put people last, citing phony precautions. There's absolutely nothing anywhere that tells you to put somebody last on any list. But just returning to the beginning, please be the change you wish to see in the world and hang on to those pledges or requests that came out from the service users. And I'm sure when you go out into your placements, you'll do a fantastic job of making sure HIV positive people are treated fairly. Thank you very much. Fastest ever. I'm going to hand you over to Billy and Cordelia now. Do you want to introduce yourselves while I get yours sorted?
Yeah, no, it's
Okay, you're right.
yeah,
You find it?
so you're, is that your chocolate?
That's all right, I'll come back for that. That's right, you carry on.
Right, okay, I'm really sorry, I missed the beginning bit of that. I had to dash for a little midday gin and tonic that I normally have in between patients. So, yeah, we're here today because it's National HIV Testing Week, ending with World AIDS Day, which is happening this Sunday, the 1st of December. Today, we're from one of the local GM clinics. We're going to talk to you a little bit about HIV, what's happening in the current landscape of the UK, review some of the transmission bits and pieces. But what I want you to do is have a little think through the slides. If there's any questions or anything that you want to ask us at the end of it, please feel free to do so. We are on Twitter, #OTRBournemouth, so feel free to spread the love across those social media platforms. Quick introduction, I've got with me the very lovely Dr. Cordelia Chapman. She is a consultant in genitourinary medicine down at Royal Bournemouth Hospital. She also works in an outreach clinic over the rainbow every Wednesday, 12 till 7. She's actually been Star Baker in 3 international countries. So please do bear in mind for your weddings, christenings, bar mitzvahs, anything like that, you have not lived until you've had a Chapman cupcake. My name's Kevin, I work as a health advisor specialising in sexual health at Over the Rainbow, and I currently hold the record for the longest time a human spent upside down. All right? Lovely. So HIV, where is it? What does it do? Where does it come from? So we first knew about HIV. It first reared its little head in the 1980s, initially amongst a gay population living in San Francisco. Here it was coined GRIDS, Gay-Related Immunodeficiency Syndrome, purely because the only people presenting were gay men. This all changed in 1986 when the first ever woman was diagnosed with HIV. Now her name was Gia Karanji and she was a real famous supermodel long before the days of Naomi Campbell and Kate Moss, and it spread light on the idea that this was actually a new infection that had the potential to be a blood-borne virus. So it could be transmitted through blood-to-blood contact. Over the period of 9 years, internationally and globally, it's probably one of the fastest ever spreading infections of all time, with 30 million people affected in less than 9 years. So, now that we're here, currently, 2013, what's happening at the moment? Well, it's estimated that currently there are 98,400 people living with HIV within the UK. Now, when I first moved into sexual health about 4 years ago, this figure was only around about 92,000. So it is something that's continuing to rise within both heterosexual and gay communities. So the face of HIV is changing. It's not just something that we're associating with Africa. It's not something we're associating with prostitutes. It's not something we're associating with men having sex with men. This is an infection that affects everybody. 22% of this figure don't know what their status is yet. Okay, so they've remained undiagnosed and untreated, and we think that they're probably responsible for up to 50% of new transmissions that happen each year. The most surprising statistic is that each year there's around about 1,000 people under the age of 18 who's accessing HIV care within the NHS. So these are people who haven't even left school yet and are already having to start thinking about living with a lifelong underlying health condition. What's it doing in the UK at the moment? Well, HIV continues to be a sexually transmitted infection. Okay, so the only way you as healthcare professionals could potentially catch it is if you slept with a patient. So generally, that's probably not good advice to be taking. When we look at what's happening against the gays and the heterosexuals, it's actually, there's only 1% within it. So before, where it was predominantly a gay man's disease, it's actually something that's equally shared across gay and straight communities, but we only hear about it affecting gay men within the media. It's only in recent years that we've started to see it more prevalently in heterosexual communities. Can anybody think why that might be? Really shitty Saturday night TV, people are staying in more maybe? No? Reporting, that's a really good one. Anything else? No. Okay.
Because of the stigma with gay,
Yeah.
so they're just labeling gay people and just, in denial maybe, I don't know.
Yeah, so a lot of attention probably is just focused on that. A lot of it is to do with the idea of what I like to call the rod. Contraceptive services are obsessed with the implant. If I still long enough, they'll actually try and put one inside me. Now, what actually happens with that is, yeah, that's great. It stops you from getting pregnant, but it stops a lot of girls from wearing a condom when it comes to having sex with people. So that's where those transmissions are taking place. As well, we've got to remember that anal sex isn't just the only type of sex that happens within gay relationships. It's widely practiced within heterosexual relationships as well. Now, I used to live in Bristol until I was banned 3 years ago, after I did a survey across Bristol to find out what anal sex Bristol was happening. So I got all the gay men together in one room. I was like, chaps, fill me in. What's going down? So, on average, gay men were having 12 sexual partners a year. Now girls, we know when a boy tells us they have 10 sexual partners a year, they probably only have about 5 or 4, right? So, if we take that as a rough average, how many of those 12 men do you think they were having anal sex with? The full 12? Half? Or none? Half? Less than half. It's actually, well done, it's actually only 2. So this challenges this conception that bum sex is all that we gays do. But also, they were actually making much more complex decisions about the type of sex that we're having. When we look at the new survey data from the National Sex Behaviours Review, heterosexual sex is starting to include much wider range of activities other than just vaginal penile intercourse. This is my little weather map of the UK. It kind of illustrates to you where HIV is spread, okay? Don't want to catch an STI? Move to Scotland, all right? We're down here. right in the depth, at the end of the world, sometimes it feels a little bit, doesn't it? Actually, we've probably got one of the highest HIV rates outside of London. I think we're the fifth highest?
Yeah, in the top 20.
We're in the top 20, yeah, forget
It's
your
always
unis
good.
and your colleges. So yeah, we're in the top 20, so we're really, really high. The national average is 2.69 per thousand for it to be a high risk, and we're 2.92. Dr. Chapman works as a consultant down the hospital, so how many people roughly do you think you've got in your books now?
It's about 850 patients. So when I started in 2006, it was about 260. So the numbers have gone up. We're the biggest centre on the south coast next to Brighton. So Brighton's got a couple of thousand.
And what kind of people do you see coming through?
So we see, like Kevin said, it's a mix. So you have patients who mainly have sex with men, and that forms the large majority of our patient population in Bournemouth, just because of our demographics. We've got people like John said, we don't look after paediatric patients. So we've got, the youngest is 16, the oldest is in her 80s. So there's a massively diverse population, and patients with HIV are living longer. So that's going to sort of start skewing. So it's not just a disease of people who are young and sexually active and etc. etc. So you can be much older and still have HIV.
So we're living in a high risk area. What can we do to prevent HIV transmission? Well, there's lots of things. You could go out and buy yourself one of these fetching outfits from Topshop in the sale. Maybe wait there, it'd be 50% cheaper. Or one of these lovely things. Guys, this did make it to the GQ Style Awards 2014. Quite like that it's a little bit retro. We're going back to medieval times. Nice big chastity belt. Will make you look maybe a little bit bigger when you're out on the pool. Or you go to the extreme end. Go on Amazon and get yourself an all-body condom. All right? Just be careful you're not wearing any jewellery as to make holes in the latex. All right? But that is probably the best thing that you can do to help reduce the onward transmission of HIV is to use a condom. And it's really difficult because when we do outreach, we go up to all the ladies and we're like, take a condom. I've even made these nice little handbag size stuff. They're downstairs on the table. Have yourselves in the little coffee bar downstairs. But they're like, oh no, I'm on the road. It's fine, it's fine. That's great. You're not going to get pregnant. One less Kevin in the world. But you need to start thinking about what you might be left with after he or she has done one. All right? Okay, so the lineup. Day after day after day, I have boys come into the clinic and I'm like, do you want to take some condoms? Like, oh no, Kevin, my penis is far too big to go in any of those condoms you've got there. In actual fact, I've brought it in over my shoulder, and when it gets too heavy, I like to drag it back through like this. Okay, they're just like your shoes. There is a size for every penis. You can go for a trim, which is a slim Jim. So if it's long and thin, going all the way in, you're probably better off with one of those. If you're a steady Eddie, you can go for a regular size, or if you're short and fat, a nice large one will sort you out just a treat. When I was in Bristol, before I got kicked out again, there's king-size condoms. So I managed to fit one on the top of a post box, which is the same size as an old lady. So just think about that when you're having sex with someone. Now,
That's also called liar, the liar size.
in America it's called Magnum, which I quite like the sound of, but I kind of expected a little tash on it at the same time. We are in November still. Boys, we have a really short attention span, and girls, it's nothing that you're doing wrong, it's just the way of the world, alright? So sometimes, when we've got you there ready to go, it can be a bit like, I've got to get my condom on, or it takes so long, Kevin. Really? How long is it? Half an hour? What happens is, halfway through, we generally get a little bit distracted by something, and we leave the condom half rolled. So there's still half of it rolled up on the base. That's why it doesn't fit you. So what we like to say is pinch, roll some more, and then roll some more, okay? So just keep on rolling, all right? And you should be all right. Now there are certain things to do. Condoms are only as good as the person that's using them, okay? And there's certain things to do to keep your Johnny happy. Always use a water-based lubricant if you need to, particularly in the summer when you might be having a dry spell. Do please avoid Vaseline, cooking oil, the really expensive face cream you got your mum for Christmas that she's not using. I've had it all. Herbal essences, definitely want to avoid. Store your stash away from extreme temperatures. Now, most of you might be in halls, but some of you might be living at home, so it can be really embarrassing for your mum finding your Johnny stash. Don't keep them handy though. Don't hide them at the back of the fridge behind the roast turkey that she's got on offer from Lidl's in April, you know, just in case we run out before Christmas. So don't keep them in anything that's too cold or anything that's too hot. Another double bag, good God, it's hard enough trying to put one condom on, let alone trying to put another one. And you're more likely to get a rip with the friction burn, or it might actually roll off and stay inside your special little friend. So, you know, just be aware of that. Right, so boys on the town, I've used an Action Man. Traces of HIV are now being found in pre-cum. So if you're having a little bit of friendly frottage, that's rubbing your naked bits against another set of naked bits. If there's a little bit of pre-cum, there could be enough for a HIV transmission to take place, particularly if that viral load is really high. Lads, our penises are like a sponge, all right? Now, when dorm inspection happens, that doesn't mean to say that you lop it out on the work surfaces and just start cleaning stuff down. But that said, it does absorb quite a lot of vaginal and anal secretion, so that's why it's really important that you wear a condom as well. Unprotected anal intercourse carries the highest transmission risk. The thinnest bit of your skin on your outside of your body is your eyelid, okay? Your anal lining is about 10 times thinner than that, and it's really easy to cause trauma to it, or to get tears, rips and things. So, you know, just that's why it's really important to wear condoms for anal sex. Ladies, I've gone for a Barbie for you now, alright? She's very current, she's doing a little Lady Gaga thing there. The implant alone does not stop you catching HIV. It might stop you from getting pregnant, but there's still the risk of other infections coming through. Always wear a separate condom for anal and then vaginal sex. There's a nice little pit stop area between the two, so you can change over in there. And opt into HIV testing as part of your STI screening, your smear screening, I want to see you all when you're 25, and your coil fitting as well. Extra benefit of a coil fitting, you get an extra channel on your TV box. So, having babies still does happen. So even if you're working with somebody that's pregnant, we do check for chlamydia at different stages of the trimester, but we also do HIV testing as well, just to make sure that we don't end up with mother-to-baby transmission through either vaginal birth or through breastfeeding as well. And Dr. Chapman will come on to that a little bit later on, I think, don't you?
Okay.
Yeah. God, she really is going for it, isn't she, Barbs? Right, so oral sex, about 8 to 10% of all HIV transmissions that we see within the UK come from unprotected oral sex. And we get a lot of questions of like, does it depend on whether you're the giver or the receiver, whether you spit or swallow? So, generally, the risk is on the gum line. So, when we've got a bit of a hot date going on, the old dental floss and the toothbrush comes out, so long as you've had about an hour or two for any sort of cuts to sort of heal up a little bit, that's generally fine. If you're swallowing, it goes through the gum line once. If you're spitting, it goes through twice. If you've got lots of ulcers or poor dental hygiene, probably not a good idea, because that itself can cause a risk. But like I said, it's only about 8 to 10% of HIV transmissions occur through oral sex. Can you catch HIV by? So, mosquitoes. Some of us like to hold on to that student loan, have a little week in Ibiza or something during the summer holidays. Could you catch HIV from a mosquito, do you think? No, good. So whilst a mosquito can take your blood, it can't regurgitate enough of it into someone else's body to make a HIV transmission. What about the old recreationals, ketamine, cocaine, when you're out with your friends and you're snorting? Could you catch HIV through that? Actually, yes, you potentially could. As the crystals are going up here, and there's a backflash, like CSI, and it's all slowed down. If that stays in the tube, as more crystals come up, it can roll within that, and with blood-to-blood contact in the nose, that could happen. So if you are a fan of your weekends, make sure you're using your own equipment. All right? Equipment, listen to me. What about in student halls? Could you catch HIV by living with someone who had the virus? No. Okay, cool. Remember, it is a sexually transmitted infection. So you are fine to have a bath with them, wash up with them, shave cutlery, things like that. It's all good. Ibiza. I know, a bath from there as well. So sometimes we get a little bit overexcited when we're on holiday. I know I do. Booze Britain 2003, I was a guest star. And we sometimes get a little bit tempted to get a little holiday tattoo as a souvenir of our memories of our time away. Just bear in mind that, the equipment might not be sterilised. I had a lady that had some permanent makeup tattooed in Thailand, HIV transmission. A guy who had a holiday tattoo on a beach, again, HIV transmission. So if you are feeling a little bit brave and you want to get like a full sleeve or something massive on your back, wait until you get home, okay? There is also a really big risk of Hep B and Hep C as well with things like tattooing, so do bear it in mind. In order for a transmission to take place, there needs to be 3 things present. There needs to be a good route of transmission. There needs to be a good quality of the virus, so a virus that hasn't been treated with medication, and there needs to be a good quantity of it. People always ask about kissing. You'd actually need about 10 pints of someone's spit to be ingested into your body before we were worried about HIV. To be honest, I'd be probably looking to get you sectioned for drinking 10 pints of someone's spit, but never mind, whatever floats your boat. I'm going to hand over to Dr. C. He's going to talk to you a little bit about seroconversion.
So seroconversion is basically where the person who's acquired HIV goes from being HIV negative to HIV positive, and they generally would experience some illness, so some viral illness, because obviously HIV is a virus, so people generally feel like they've got glandular fever. And you can say, oh, your GP sees hundreds of patients every winter with fevers and a bit of a sore throat. But if you suspect HIV, you should obviously speak to the person about whether they have put themselves at risk of HIV. If you have fever, a sore throat and a rash, those 3 things together would be highly suspicious of HIV seroconversion. If you want an HIV seroconversion to test somebody around that time, you'd need to tell the lab, just so they'll do some fancy tests on it, which I don't understand, just because sometimes the test can be just changing, so you're becoming, as I said, you're becoming positive from being negative, and also the test might not show up straight away. So you need a high index of suspicion to suspect this. It's 90% of people will have an illness, 25% of those people go to the seek healthcare professional input with that illness. It's very short, it only lasts a couple of weeks. So it can be just totally forgotten about, the risk and then the illness, people don't put those together. Has anyone heard of this, post-exposure prophylaxis? Yeah, so that's, you can either give it occupationally, so if you have a needle stick injury, and the SE, so PEPC, is through sexual exposure. So it's given within 72 hours of potentially being at risk of acquiring HIV. It's the same drugs that we use for patients with HIV. We use a specific group of drugs. You have to take those, as I said, within 72 hours, ideally sooner than that, and take them for 1 month, and it significantly reduces the transmission risk or the acquisition risk of HIV. They're pretty toxic drugs. They're not licensed to be used for this indication, so when we get called at 4 in the morning and have to make that decision, we obviously have to weigh up the pros and cons of doing that, because we're taking full responsibility of prescribing those drugs off licence. They're very effective. Your plug, I'm going to leave it to Kevin.
Yeah, my little plug here. So, National HIV Testing Week, what I want you to do is I'm just going to leave some of these on each side, pass them down. I want you to do the scratch test on the 3 questions that's on there. If it comes up that, they advise you to have a HIV test, what I want you to do is, as you leave today, if we had the funding to provide finger prick testing here today, would you take the test or would you take your chances? All right? So they'll get passed to you now. So just drop those in either box as you leave a little bit later today.
So HIV is diagnosed through a blood test. So we take about a teaspoon of blood, which seems like, it's not that much. We don't drain your arm or a leg. And yeah, I understand. The terminology can be a bit difficult to understand. So somebody's HIV positive, that means the virus has been found in the body. Obviously, generally, we think positive things are sort of good. And obviously knowing your HIV status is good, but then having that diagnosis, as John said before, is very devastating. Negative means the HIV virus you haven't been exposed to HIV, so that means you still need to carry on using safe sex and having regular checkups. And it takes up to 4 weeks for the virus to show up for the blood test to become positive. So if you have sex before that time and you want an HIV test, it's not going to necessarily tell you about that time. You have to sort of count 4 weeks backwards every time. And we say you should really retest at 3 months as well, because syphilis, hepatitis B and C takes up to 3 months to show. So if you want the full works, come in at 3 months. Viral load, this is what we test on patients with HIV. It gives an indication how much virus is in the body. We use that to determine how effective the treatment is. So the goal of treatment is to reduce the viral load to undetectable, so below 50. And that means that your risk of transmission is very low. The risk of the virus destroying your immune system is significantly reduced. And then the CD4 count is the marker of the immune cell. So that's the immune cell that HIV directly infects. It's pivotal in the immune system. Normal range, if you took everybody's blood here for CD4, it would be a very wide normal range, and it's not a test that's done routinely. We normally don't recommend treatment unless the CD4 count falls below 350 in somebody who doesn't have any symptoms. We wouldn't not start it if somebody wanted us to start it earlier, and we are looking at whether starting people on treatment as soon as they're diagnosed is more beneficial. It obviously has clear indications for reduction of transmission. If people are older, if they've got a higher viral load, if they've got heart disease, kidney disease, or if they're hepatitis B and C co-infected, so they've got both infections, we would think about starting treatment earlier. Once you go below 200, that's the danger zone. That's when infections that you would normally be able to fight off if your immune system was functioning okay, people with HIV with a low immune system struggle to fight off these infections, and they can be very serious. And that's where the original cut-off of AIDS, we don't really use that term now, it's very emotive, the media love it because it sells lots of papers. In my profession, we don't really use that term anymore. So John said to the last group, patients with a low CD4 who are HIV positive, who've got one of these infections, tend to like to be, not labelled, because it's not a label, but say advanced HIV is much more acceptable as a term than AIDS, okay? So as soon as your CD4 count goes up, officially you don't actually have AIDS anyway, and obviously that reverses with treatment. So as I said before, the viral load is very high at seroconversion, so when you get infected, then it will fall down with treatment. As I said, the goal of treatment is to make your virus undetectable, so it's not replicating, it's not going to damage your immune system, and the risk of transmission is very low at that point. CD4 count obviously goes the other way, we want it to go higher. You can't flog someone's CD4 count if it was 500 before they're infected, you can't flog it to 1500. Some people say, oh, my friend's CD4 is 1500, mine's only 5. You can't make your body generate more CD4 cells in the sense you can't push it above, you can't flog the marrow in the bones. Treatment is very effective. It's revolutionised. We used to have to get patients to take their medication 5 times a day, had to get up in the middle of the night, set their alarm clocks to take it 5 times a day. It was very toxic. Now we have 1 pill once a day, drugs available, which obviously is very convenient for patients. The tolerability, so the side effect profile, has reduced significantly. So again, that's the reason why people want to start treatment earlier, because it's much more easy to take.
Okay, so people living with HIV, they don't just have relationships with HIV positive people. In my clinics, I would say that 70% of couples that come in, one of them has HIV and the other one doesn't. So those relationships are still able to happen. They are still safe as well with the pharmaceutical technologies we have and with condom wearing. You can go on and have a baby as well. We can do sperm washing, put mothers on treatments and things like that. So you can start a family if you want to. You can have any job that you want to have. It doesn't stop any of that. The only job you can't do at the moment is to be a surgeon, but that's all changing within 2014, as long as it's undetectable and you've been engaging within a GM clinic. Please remember that every one of you in this room has a HIV status. If you're positive, it's your responsibility to engage within the GM services to help you live a full and happy life. If you're negative, you've got the responsibility of coming in twice a year minimum, or whenever you've had any unprotected sex, plus 4 weeks, come on in and we can do testing for you there.